All right, we're back. We have Jim Eubanks. Jim has been a phenomenal resource and friend, and was introduced to me through Geronimo Bejarano, who was a prior guest. Jim, you have a very unique background, and I want to get into how you ended up where you currently are. But can you initially give a current kind of intro on your current roles and titles, and then maybe how'd you get up to this point before we dive into the topic for today?
Yeah, absolutely. And Chris, it's an honor, to be here and to speak with you again. Geronimo's a great mutual friend, as you know. And so I was a chiropractor. I went to Logan in St. Louis, um, got out into practice in Charlotte, and soon began a sort of a mentee relationship with a guy named Craig Brigham, who's a spine surgeon or was a spine surgeon at Ortho Carolina in Charlotte. Um, And, I've told this story a few times in different ways, but he was speaking about the biopsychosocial model to this large group of mostly surgeons in Charlotte at the Charlotte Orthopedic Hospital. And it just impressed me that he, knew what that was and some of the things he was saying. And so afterwards, I went and asked him if I could spend some time with him, and the rest is history. It sort of changed the course of my life. Um, I went and spent time in Boston with a guy named Jim Rainville, who was a physiatrist. He retired a few years ago, but he was running a comprehensive spine pain program at New England Baptist Hospital, heavily dependent on exercise-based strategies, rehab, and had close PT partners. And I was impressed with what he was doing, and it sort of turned me on to PM&R, or physical medicine and rehabilitation, also known as physiatry, um, which is what I do now. So I went to medical school at East Carolina in Greenville, North Carolina, knowing I wanted to do that field. Stayed the course, ended up going to the University of Pittsburgh for my residency. And then I stayed on for a year fellowship in value-based spine and musculoskeletal medicine, which was a fantastic experience for me. And then I had planned to stay on faculty there. Still am. I have maintain an affiliation as a clinical assistant professor. And but I came to the Medical University of South Carolina, MUSC, in Charleston, where I am now, this past summer. So I came in July and started work in mid to late August. So we're in the Department of Orthopedics and Physical Medicine. We are the division of PM&R, which is the first academic PM&R presence in the state of South Carolina. And we are developing a residency program and have grown quite a lot with our faculty. So I think we'll be around 12 faculty from virtually zero by next fall. Inpatient and outpatient consults, and we are thriving. And so it's been a great environment to work in and to carry a lot of my training and background here, to sort of infuse that in the development of a brand new culture.
And the topic for today is on lumbar spinal stenosis, which you're intimately familiar with, and just general spine rehabilitation and management. Jim, can you start with just defining what even is lumbar spinal stenosis and who does it typically affect?
Yeah, so lumbar spinal stenosis is really one of the most common degenerative age-related conditions that we acquire as human beings who are fighting gravity for decades. It is one of the blessings of living a long life. And so most people will have some aspect of stenosis, whether that is through their symptomatology or just radiographically. And there's some differences there that we can talk about later. But there are many different structures in the spine that change as we age, and this is part of a normal process. There's nothing really intrinsically disease oriented about that change. It's just that it so happens to affect us in ways that we might feel that. Some people are more sensate to what's happening in their spines throughout life, and others are more insensate to that. And there's a spectrum there. Probably most people fall in the middle, where intermittently, occasionally, they might have some symptoms that comes and goes, or is not so burdensome that they need, much intervention. They might just need a little advice or guidance occasionally, take some medications, modify some activities, that kind of thing. But spinal stenosis is the age-related process, really an osteoarthritic process that leads to a decrease in the amount of space for the nerves. And that can mean centrally or central stenosis, where either the spinal cord itself or the nerves that are comprised of the lumbar spine are traveling through the canal. And the ligamentum flavum, for example, as we grow older, our discs are what cause us to shrink. And so this is a common point of education with patients in general. Everyone notices that 90-year-olds are not the same height that they were when they were 25. And so where does that loss of height come from? Primarily, it's the disc. And as we age, those discs, they get drier and thinner. And that's a normal part of the process. Again, just like hair graying or skin wrinkling, but it happens inside of us. As those discs dry and thin out, it leaves a little bit less room in the spine. Some of that is because the ligamentum flavum, for example, buckles. It's not as taut as it once was, and so if you lose height, it sort of buckles inward, and in some people, it can press centrally. We also have other processes that are involved. So the facet joints, for example, they also undergo osteoarthritic changes that might lead to some osteophytosis or bone spurring or some bone growth around those joints that, again, crowds out typically more the foramen or the holes, where the nerves are exiting and going into the arms or legs, if it's the neck or back. Which is another location of stenosis, foraminal stenosis or neuroforaminal stenosis. And so the combination of elements that are undergoing change that lead to a decrease in the amount of space available for otherwise fairly sensitive structures, the nerves, our eyes are nerves. And I always use the analogy that if you get a simple 1 grain of sand in your eye, it can, become extremely irritated and red. It's a noxious experience. And so nerves, they don't like pressure and they don't like traction, right? And so if a stenosis leads to pressure, we might feel that symptomatically. And if that pressure leads to an inability for the nerve to sort of normally glide or slide as it does when we're walking, it can get more taut, and therefore traction injury might become part of that process as well. And so those are generally the things that are happening with stenosis. Again, it's a normal phenomenon, but we may feel it in a way at times that is symptomatic and uncomfortable. And so that's what we're left to deal with, as clinicians.
Do you want to touch on, you briefly discussed it, but radiographic versus clinical findings?
Yes. So stenosis is interesting because many times people will come in with more classic neurogenic claudication and not have positive exam findings. And so you'll instead have to rely on the history. And that is a history describing the sort of intermittent stenosis process that people experience, particularly standing and walking versus sitting or flexing. The shopping cart sign is something that just fascinating, that the number of people who will explain that to you without any prompting. And so they'll just comment on the fact that, yeah, when I go shopping or when I go to the grocery store, I find myself using a cart and I feel better. And they don't sometimes know why that is happening. And then I explain it, that when you flex forward, you're kind of opening the canal and the foramen a bit, so it decompresses those nerves naturally. And that's why a flexed position is preferred in many people with stenosis. But we may not find neural tension signs. We may not find overt weakness or even sensory loss. Sometimes we do, depending on how advanced the stenosis process might be in them or how damaging it is to their nerves in particular. But often we do not find many pertinent positives on exam. Sometimes when we go hunting for other etiologies, we might find radiographic stenosis, which is, there are different classification systems. So the Lee grading system is a 0 through 3 that is based on the amount of CSF that is obliterated. And so that grading system is frequently used by radiologists. The Lurie grading system is another one that's just kind of mild, moderate, and severe based on the amount of space that's been compromised sort of in thirds. And so those are two examples of radiographic etiologies of stenosis that might be described. But the disconnect is in the symptomatology. So sometimes people have what looks like moderate or even severe stenosis on their MRI, and yet do not complain of symptoms, or do not have symptoms where we might predict by the imaging they might have symptoms. And what I think that leads us to realize, which is true in all of MSK, of course, and it's our constant battle with ourselves mostly, but we cannot really predict who becomes symptomatic. So in lumbar spinal stenosis, some people seem, again, very sensitive to the process, and some are not. They're relatively insensitive to it. And I do think the bulk of us are going to fall somewhere in the middle, kind of here and there. Maybe it's never enough that someone goes to a clinician for help, but they occasionally experience the radiating leg pain, or they have some days of discomfort and that sort of thing. And then they wait a week and it kind of gets better and they decide not to go to the doctor or whatever. That's happening out there in the community. And so we just don't have a good grasp yet on why some apparently moderate and severe stenosis on imaging doesn't lead to symptoms in some people, but seemingly does in others.
Can we dive into an example or a situation where a patient's presenting to rehab with reports of low back pain, maybe leg pain? What, from a physical therapist perspective or rehab provider, would you be looking at from a differential diagnosis and ruling in or out stenosis and your perspective there? And then maybe we progress to, they have these findings, they're now seeing you as a physiatrist. What does your examination and process look like?
Yeah, so generally speaking, with stenosis, the kinds of things we're thinking about, mostly stenosis is leg pain that people will describe. There are cases where it is not as common, but there are cases where the primary symptom is back pain, and it is worse with standing and walking. It kind of sounds and smells like stenosis. They just don't have the classic radiating leg pain component. But there are noxious reasons for back pain to occur with stenosis, the stenotic process. And so that's less of a concern. Generally speaking, though, we're talking about leg pain here. And so with leg pain, I think about age groups. And so it's extremely rare for folks, less than 20s to have a disc herniation. And they come into the clinic with like a hot radiculitis or something, and they need our help. Now, that does happen. I've got a teenager who just came in recently with that. And so it does happen to younger folks, but it's less common. And so generally I break it down into like, 30 to 50 is sort of the prime time for disc herniations. The disc in most of those folks is still pretty well hydrated. It's juicy, and it can bulge and herniate and sort of change relatively abruptly. Whereas when you get past 50, the disc is drier. There's a lot less water content. The proteoglycan sort of ratio changes, and discs don't abruptly change at that point. They gradually change, or they are relatively codified at that stage in life. And so I break it down by age. So like if a 65-year-old comes to me with leg pain, I'm not thinking about a big disc herniation most of the time. Again, rare, sort of tail end of the spectrum, you'll have an older person who actually does have a disc herniation. But most of this is the arthritic sort of degenerative processes that we described initially here in the conversation. And so the other things that we think about with leg pain that are really important not to miss are vascular causes, right? Particularly in that 50 and up age group. We also are concerned about DVTs. So that's a real concern out there, something that we must look for. Is there any asymmetry in what the legs are doing in terms of edema, warmth, more localized tenderness, things like that don't quite fit a stenosis picture. And then we also have a higher prevalence of peripheral neuropathy in that age group. And so, unfortunately, a lot of Americans have diabetes now. And I have realized, being out in practice, that many of them are not well controlled. Something that I kind of talk about regularly with my patients, even though I'm a spine doctor, is trying to optimize their diabetic control. But those different processes that are relatively common are kind of the ones that always have to be on the radar. So those are always being ruled out. Older folks, is it real neurogenic claudication where the nerve's getting squished in a way that they feel it when they stand and walk, and that's what they tell us? Or is there a vascular issue? And that really comes with risk factors. So if they've had a stroke, if they're on antihypertensives, if they're on cholesterol medications already, and those things are just telling us that they have vascular pathology already, then we need to be thinking more thoroughly about getting a vascular workup to exclude that as a possibility. With peripheral neuropathy, so I do EMGs. EMGs can be helpful. EMGs are user dependent. And so sometimes as nerves get older, it's a bit harder to get a really good read on them, but we can pick up on clear cases of neuropathy in many times that is helpful. And so those are sort of the things that we're thinking through for the most part. Yeah. Obviously with any kind of radiating pain, we're also thinking about joints that are proximal or distal to the complaint. So the hip is always something I evaluate for in every single low back or spine patient. The knee has to be evaluated. It's rare for someone with actual stenosis to complain of no pain until they get to the ankle, right? So the ankle exam is slightly less important than a hip and knee to stenosis, but occasionally you'll have folks where you have to figure that out too. And those are the joints that we're thinking about for the lower extremity in particular.
And so when they are coming to see you, what does your process look like from they're diagnosed with lumbar spinal stenosis, they're in this moderate to severe symptom category? What are you educating them on of what the next steps are? And then what are their management options?
Yeah, great question. I love this question. I think it's really kind of the most important thing is how do we actually work through a case of lumbar spinal stenosis? In this case, we're talking about the lumbar spine. So I am a spine specialist. So about 75% of my practice is spine, and I'm kind of an MSK generalist. So 25% of my spine is primarily shoulders, hips, and knees. And so as a spine specialist, the patients that I see have already seen, between 1 and 14 other healthcare providers, right? Or professionals. And so these generally aren't 2 weeks of acute back pain people that, have had no instruction whatsoever off the street and they don't know what to do. Usually they're a little bit more deep into the process. Sometimes I do see searing radix where it's like a younger adult, and they're added on the schedule late because someone has requested it out of uncertainty as to what to do for them. And it's clear that this person has like a massive disc herniation. And in the past 3 weeks, I've had 2 of those, right? I knew right away it's a massive disc. I mean, that's what happens in this age group. That's what causes their symptoms. Their life was fantastic up until, point A, and then it changed. And now they can't sleep. They can't pick up their kids. They can't do anything, and they're panicked. That's a different type of person. But you kind of want to have steps in mind. And so, my first step is almost always, with the exception of like hyperacute issues that I have to work up in a specific way, have they had sufficient robust physical therapy? So I get a lot of folks from primary care, and a lot of folks from advanced practice practitioners or providers who are part of like neurosurgery or another branch of orthopedics. And those patients that are sent, I want to make sure they've been optimized in all of the sort of guideline concordant ways that we would want. That's true for lumbar spinal stenosis as well as it is just regular old back pain. Because, and I tell people this, the reason we start there is that the majority of people will improve that way. That's why we do it. There's a good rationale for it. There is a lot about lumbar spinal stenosis and in all of MSK that is natural history. And as Jim Rainville likes to sort of quote Voltaire, you're trying to entertain the person while nature takes its course, right? That's sort of what we're doing. We would like to give them something to do while they hopefully improve that is good for them and will make them better and will make their health better. And so physical therapy fits that brilliantly. There are some people who are really lifelong exercisers or have a trainer or have some commitment to a sport. And those people I may just reassure them with some education and send them back to more of a graded strategy to return to the things that they love to do. But most people need some hand holding. Again, if we're talking about spinal stenosis, we're talking about older folks. And unfortunately, as we get older, the risk of us doing less consistent, regular exercise increases. And so that's why physical therapy is this excellent bridge between a healthcare professional and a coach, or someone who can actually guide in a way that means something to behavior change. And so sometimes within that strategy, I will ask the question, did they have the right kind of therapy? Because I think one concern that is a concern for me and patients sometimes is that the therapy they were given seemed to be a mismatch from what they needed to feel better. And so commonly we might hear that there was a lot of focus on, dry needling and e-stim, and just not enough on exercise or returning to golf, or returning to walking. And so that's where, I might try to contact the therapist and say, can we do a different strategy now? Why don't we focus less on stretching and more on aerobic capacity or strength or whatever the thing is? And so I think that's important too. As I mentioned, there's some people who just need advice and education because they don't know what the right thing to do is. They're confused. And it's not that their symptoms are so bad that they demand something be done for it, as much as it is they want to be reassured that they're not going to hurt themselves by going back to do what they like to do or to continue things as they are. There are certainly people who do really well in group classes and working with trainers, and walking with loved ones. And so figuring out what it is that a person will stick to is essential, I think, to getting a good outcome. And so that reading into that and trying to pick up on the cues that patients subtly give us is something that we have to do in order to successfully treat a condition that is age related and virtually happens to everyone who lives, to 65 or more. And so that's really important. Now, there are people that are more symptomatic and need more radical changes in their treatment options, right? We have some ability to prescribe aquatic therapy. So for folks that are dealing with knee osteoarthritis or multi-joint osteoarthritis, folks with stenosis, I think getting in the water is really beneficial because it's an anti-gravity strategy. And they feel better. And so if we can get them to feel better while moving more, then that's sort of the desired outcome, right? Because there are people who don't tolerate land-based therapy well because of the gravity component. So if we can unload them from the gravity element and get them moving and maybe let the natural history part of it play out a bit, then that's another strategy I use. So I do sort of selectively send people to aquatic therapy. And we have a few ways to do that where I am now. Sometimes folks have a more severe kind of stenosis where there might be neuropathic pain aspects to their description of what they feel. And that may be a place where I do talk about some anti-neuropathic medications. I'm pretty selective about that. It is not the go-to. I think that's the mistake that many of my medical colleagues make, is that they throw gabapentin at everyone who describes stenosis. And then, of course, you get a very poor success rate in terms of that medication helping anyone, because you're giving it to a lot of people that it should have never been given to in the first place. But if we're more selective about folks that have like a true neuropathic etiology, then that, relatively unimpressive but small number needed to treat for neuropathic pain becomes more successful. And that's where those agents can be helpful. We also really have to think about confirming the diagnosis. And so that's another part of what I do. Sometimes if we don't have a good understanding of why someone has the pain, we might not have a successful treatment strategy put together. And so if someone has a spondylolisthesis that is moving 8 to 10 millimeters on flexion extension films, which I've had that patient recently, that is a different patient than someone who has no movement in their spine. And so sending a patient with a sort of some dynamic instability to do yoga or some kind of aggressive stretching routine probably is not going to make them feel great. And I would want to know that granular level of detail so that I can counsel them better and give them strategies that I think might actually help them more. So that's important. I think that like everything in MSK, we have to be very specific about what we recommend when it comes to interventions. So I do think that there are some people, the small minority of people who end up requiring surgery to decompress an impossible structural situation that nothing we do can fix otherwise. So we will have that discussion if needed. If they're just not responding and their life is ruined, right? So if there's severe disability going on, we have to have those conversations and not be so kind of blinded to a particular treatment that we don't understand when another treatment that we may not provide is the right one for the patient. And then injections that may try to differentiate where the problem is can be important and helpful. And I think in some patients, if they are really struggling with a pretty specific radicular issue, like it's the left L5 and it's clear that that's their problem area, putting some anesthetic and steroid medication beside that nerve can be life-changing to those patients. So that's sort of the process. You're thinking through all of that. Again, it's a robust sort of a physical strategy that we start with, heavy on the education, heavy on self-empowerment, but we do tailor the needs to the patient in front of us.
Do you have advice, or can you give an example of when patients are questioning the benefit of activity modification and exercise with the assumption that this is a degenerative process? How is exercise going to help alleviate this? Shouldn't I get surgery? Don't I need injections? How do you discuss the benefit while also acknowledging the uncertainty around why it may be helpful?
Yeah, that's a really big question about behavior change more generally. And so I try to zoom out and get them to understand something as basic as the core elements to living well, right? So kind of put the spine stuff aside for the moment. There are, diet matters, sleep matters, stress management matters, the reduction of high risk activities like smoking and heavy drinking matters, and our physical life matters, right? And so that's kind of where I zoom out to, and then I try to get them to understand why does being fit as I age important? And it has a lot to do with things that have nothing to do with spine, right? It's for like pulmonary and cardiovascular health. It's stroke prevention or reduction. It is blood pressure management. It is diabetes management. It is improving sleep, which it does. It is brain health. It is all of these other things that are important for your spine health. It is, and this is a big one that I, wanted to touch on a little bit later, your bone health, right? And so there's so much about being physically healthy that is necessary for anyone to age well, that's the more important message. Because if I can get them to buy into that and to understand that, then when I say, and people who have spinal stenosis who do exercise or have some physical activity engagement that they like, they handle stenosis better. They are in a better position in the event that they need something like surgery, right? You're going to handle that better. And so that's sort of how I deal with those folks. Fortunately, and a little bit of it is where I currently live in Charleston. A lot of patients are a bit more active because the weather is generally good to go walking outdoors, and so I can always kind of start with, well, hey, just go for a walk, right? Like find a park or beach that you enjoy around the area and just go for a walk. Most people don't push back too hard on that. But yeah, that's the thing that I do is I have to like dial it back and say, well, why does physical activity matter at all?
For these more typical presentations where there is that shopping cart sign or they prefer this flexed position, is there also education or awareness on, is this going to be a long-term modification? Should they incorporate an assistive device? Should the aerobic exercises be in more tolerable seated, water, aquatic-based positions? How much of this is short-term modification to hope natural history is going to run the course, or multi-year, does this make more sense long-term? Maybe we adjust these strategies of the position of your day-to-day to allow you to walk more or improve kind of your quality of life.
Yeah, excellent question. So, lumbar spinal stenosis, like any kind of osteoarthritic process, is a lifelong condition. We don't reverse it. There are a few joints that we can totally replace, hips and knees. And in hips and knees, 85% of people do well, 15% don't, but 85 do. And so we have options there, but lumbar spinal stenosis is something that we live with and we try to adapt to. And again, for reasons we still don't have a great grasp on, people can adapt to stenosis such that it gives them trouble or symptoms at a certain point, and then their body accommodates and sort of makes some adjustments that we're trying to understand still. And because that happens and is a very real phenomenon, probably for the majority of people, we can give people that information and let them know that activity modifications may be temporary or may be something that is just part of the process of adapting. And so I do have that conversation with them. I'm always open and honest with folks about the fact that some don't. So some do have these issues in a sort of persistent fashion where, they used to enjoy golf and now they're miserable when they try to golf because their spine just won't let them do it anymore. And we explore other ways of maybe transferring that sort of activity energy to something else that they enjoy. So that's part of it. I never tell people to stop doing stuff. I always make the patient be the one to stop doing something, because we don't have evidence that doing a certain activity is going to lead to doom and gloom, right? That's not how it happens. The exceedingly rare cases where there is a neurologic injury that is approaching or at the point of being irreversible, there are clear signs on exam that we should pick up on as their care partner, healthcare professional, and that's our responsibility to find that point. Which has nothing to do with telling them to stop doing something. It has to do with finding it and saying, we're at that moment where we need to save your nerve or whatever. And again, exceedingly rare, does happen in life. It is out there. But most people don't have to deal with that. And that's important for us to know and us to communicate with them, because people have undergone procedures that they regret because they were scared into it. And no one should ever be scared into a procedure, so to speak. They should be informed about what the particular procedure can and can't do for them, and why they may be at a moment where they have to make that decision, right? So, yeah, it when you think about it as a lifelong condition, though, it makes you think differently about how to manage spine patients, because we used to think about it as a very episodic thing where it just happens and we deal with it and we sort of send them out on their way. But now we want to be thinking in a lot more detail, and that's where sort of the general health considerations come in, which is like the diabetes management. So having a good control of one's diabetes is really important to nerve health, right? Lots of other things. Lots of organs are damaged from uncontrolled hyperglycemia, but there are very specific neuromusculoskeletal reasons to care about it. And so for my patients who are not optimized with their diabetes management, every single one of them is offered for me to refer them to an endocrinologist, because that is the standard of care in 2024, that everyone who has access to an endocrinologist and has uncontrolled diabetes should be offered it. So that's part of my practice as a spine doctor. I do that every time. Additionally, I want to make sure that my patients are optimized from a cardiac perspective, because vascular disease and a high risk of stroke is something I care, deeply about as a physiatrist or a physical medicine and rehab doc, because I cover consults. I see people with the devastating consequences of stroke that have their function in life permanently altered because of these diseases. And that is something that I care about, in my patient population. And so I make sure that they're optimized. I had a patient recently who we got a brain MRI on, and there's evidence of multiple strokes that have been happening. And he has a atrial fibrillation that's uncontrolled on the current regimen of medication. And so my, most important step as a spine doctor to this guy, whose back pain melted away as a priority while we're having this conversation, my first priority becomes getting them back to cardiology to optimize their medications to stop strokes from ruining their life. If we care about function, stroke's a big one. One of the other things that's really important in my practice is bone health. So when you think about stenosis and walking and peripheral neuropathy and these things that affect people's mobility and the safety of moving, I don't want them falling, because we know that if they have bone demineralization, like osteopenia or osteoporosis, that is not treated adequately, their risk of a fracture with low energy impact is much higher, many times higher than it would be if they had normal bone density. And so I do get a lot of DEXA scans on folks that are high risk, either because family history, prior medications, they've been on long chronic steroid use for a rheumatologic issue, women who reach a certain age. There are also folks like those with ankylosing spondylitis and those with widespread dish, who are inherently more at risk of having bone demineralization, even when they're younger. So I've, 50-year-old males with AS, I've caught with osteoporosis that was totally unknown. They're still working, sometimes doing high risk activities. And we have more effective ways of treating osteopenia and osteoporosis. Many lifestyle factors matter. Reduction of harmful substances, again, excessive alcohol use, tobacco, adequate dietary intake of essential nutrients, and then we do have medications for those that are at higher risk on that spectrum that work quite well now. And so all of that matters, to me as a spine doctor.
You may have touched on the majority of what you wanted to touch on here, but
Mm-hmm.
if you want to add anything, the program you were with, or still currently with UPMC for spine health, and how that pertains to lumbar spinal stenosis, if you want to touch on that and what that looks like and the importance, and then under that, this value of team-based care, which you've already been discussing.
Yeah. So I did my training at UPMC, and Chris Standard runs the program for spine health, which is a really great concept because spine health changes the way we think about patients with spine conditions. And what it does is it tries to frame it as more of a lifelong consideration. So an example is, if you have a young person with a disc herniation who's struggling for a brief time, it may seem, with a radiculitis, we know what can go wrong in, let's say, that 30-year-old person if they aren't given the right information and they aren't progressed along a positive recovery pathway. We know what their life may look like in 10 years or 20 years, and it might be very bad for them. Spine health makes us think about that. So spine health, the way I was taught, with Chris Standard, is, and he's a physiatrist at UPMC who was at the University of Washington for many years. And he came to UPMC to develop this program. But what I was trained to do is to think about every person in their potential trajectory from the moment that I see them, and how I can hopefully move them on a positive course over the next several years versus them moving, on a downward course. And I think that comes from the understanding that the healthcare system has disabled so many people because of poor management strategies. And we're at a point where we know enough to better inform people about how to avoid that really iatrogenic disability from happening to them. And so that is what I love about this idea of spine health, is it really tries to take a overtly positive spin on these conditions, and force us to think more thoroughly about the implications of what we do today in clinic. Team-based care, I cannot do my job effectively without other professionals. Cannot do it. There is no single type of professional who can do everything I've been talking about, right? I am not the diabetes specialist. I cannot fix everybody's diabetes, which is essential to my spine patients doing well. I am not the cardiologist. I can't optimize everyone's cardiac meds in a way that's, best suited to reduce their stroke risk or their vascular disease. I need people and partners to do that. I'm not the physical therapist. My practice is very busy now, and it was rapidly busy because PM&R didn't really exist here, and it was you you didn't have anyone kind of between PT and surgery. You really didn't. And so it's fascinating to go into a place that didn't have that, and then to start offering it and to see it just unfold. And the build out here has been very impressive and remarkable. And our division chief is a guy named Dr. Amit Nagpal, who's done a phenomenal job recognizing, to use sort of the popular idea, putting the right people on the bus, to achieve the goals that we decide as a team is most important. And we're able to do that now. And I think that we have a fantastic opportunity to figure out how to use our colleagues to provide the best possible care for our patients. And that's what we're doing. And so I love working with and getting close to our PTs in the area. I love figuring out how I can get aquatic therapy to patients. I work with a pain psychologist here, Dr. Charlene Whedon, who will take my patients that need that level of care to better understand what's happening to them. And she's brilliant with it. And I've had lives completely transformed by the work that she does. And she does work that I can't do. She can spend an entire hour sort of exploring a patient's personal ideas about what's going on with them in ways that empowers everything else that I have offered them. And so that's kind of where I am with things. It's nice to work with a group of surgeons who deeply value their non-orthopedic colleagues because of this that I'm describing, which is understanding the full continuum of care and how, no single one of us has everything that we can provide that people need.
Yeah, I appreciate you diving into all that and the reality of not forcing ourselves into silos, because that doesn't help anyone. Right. As we wrap up, is there anything else that you wanted to touch on, or any big take-home points for providers, particularly rehab providers, that you'd really want to emphasize?
Yeah, actually, so one of the most impressive experiences I've had with a patient over the past 6 months was me understanding what was needed to really transform someone's life. And so the example is I had a patient who had a below knee amputation and was using a prosthetic leg, but having a lot of difficulty using it with stairs safely. And the person was living in a situation where, the landlord did not build a ramp or wouldn't build a ramp by request of this person. And this person, unfortunately, had falls because of trying to navigate stairs, leading to symptomatic compression fractures, which is how I saw the person. And, hearing the story about what this patient needed and the obstacles that this patient faced led me to realize that they needed a ramp to enter their home safely. So what I did as my treatment, part of my treatment strategy, was I wrote a very complete letter to this landlord explaining the situation and why a ramp was essential. And we had a ramp built within 48 hours. And it solved the problem of entering the home safely. And so, there have also been cases where I've had to leverage social work because the nature of the health obstacle that a patient faced could not be overcome unless there were some instrumental social needs met or dealt with. And there are often patients who are unaware of resources available to them. And so I've ordered social work consults, to be sent to people's homes. And so I think, my point there is that we really have to think comprehensively about what the actual obstacles are for people thriving or doing well. And realize that sometimes, an injection or taping or stretching is not going to address the real issue that someone's facing. And despite the concerns that we often have about not being empowered to get people the information or resources that they actually need, things are changing quite rapidly in healthcare. And I think there are many emerged resources that folks listening may not even be aware of or aware is available to them yet that they can leverage and use with their patients. And so being on the lookout for that and trying to constantly build a new toolbox is something that we have to do, because our commitment as rehab professionals is in the full rehabilitation of a person so that they thrive and that they are healthy in the bigger sense. The spine and MSK stuff does become somewhat secondary for rehab professionals, because I think our first and foremost commitment is to the successful opportunity for our patients to do well.
What are some of those resources that you just mentioned? Or we can just link them in the show notes.
Yeah, so it kind of depends on location and what's around you. One example for me has been pain psychology and social work. I had never written a letter before to a landlord asking them to build a ramp for a patient. So I just did that. I didn't know what was going to happen when I first did it. And then I was very pleased and impressed with the outcome, as was my patient, who's been, extremely grateful for that. But exploring community resources is really, really important. So and that'll mean reaching across the aisle. So finding folks that are not in your sort of subset of healthcare or profession to ally with. So one thing I've done at MUSC that has been really helpful is I've given talks and I've shared kind of my way of thinking in PM&R with other groups, surgeons, physical therapists, occupational therapists, and in doing so have created a much bigger network of people now all of a sudden who want to be part of that and who themselves know about things that I didn't know about. Right. So they improve your reach. And I think that's part of it. MUSC, like UPMC and many institutions, have their own kind of repertoire of community resources that you can tap into. And so like in our medical record, there's even like dot phrases that you can just hit and it will populate automatically different types of community resources for people struggling with, substance dependency, or people suffering with food insecurity or housing issues, all of that. And so being aware of it, I think, is really important in that consideration within your local area or region. Because again, there's nothing that prevents us from having that to offer our patients. And I think especially rehab, professionals and people who are doing rehabilitation for a living, that is part of our obligation. Like that's in our wheelhouse. That's what we should be thinking through. Yeah.
Yeah, I agree. I appreciate that. Let's call it there. I think that was a great way to end. I think we navigated the landscape of more specifically managing the progression of lumbar spinal stenosis and what treatment options there are, but also zooming out and understanding as a whole how to manage the complexity of humans and what resources are beneficial for them as a whole. So yeah, thank you, Jim, for all of that. Any final thoughts before we call it?
No, I'm happy to connect with people. So, I'm on formerly known as Twitter, J Eubanks, MD, and I like to share what I think is sort of high impact information or research there. And then I'm happy to connect with folks, jim.eubanks@gmail. Um, and otherwise, if people have other ideas or things that resonate with them, I'd like to hear about that. And I really appreciate the work you do, Chris. And it's always a pleasure to talk with you. And I hope we do it more.
I appreciate it, Jim. We'll call it there. Thanks.